Greetings, my name is Lindsay Ma, and I'm a rising intern in the Department of Internal Medicine. Today we'll be covering how to diagnose and initially manage acute stroke. The target audience for this talk is clerkship level medical students, so let's see what we can learn today. To start, stroke is when there is a sudden lack of blood flow to one or multiple parts of the brain. Swift diagnosis and initial management can reduce the neurologic deficits from an acute stroke that has occurred within the last 24 hours. As always, the first step is to ensure the patient's ABCs are intact. Next, we'll want to make sure they have MOV, or monitors, oxygen, and venous access. Once the patient is stabilized, let's run through some of the items that are on our differential. Although this could be stroke, it isn't necessarily stroke, so we want to consider some of the other items that might apply to our patient. On the one hand, we can think about differential diagnoses for conditions in the brain, including other hemorrhages such as ICH and SAH. TIA is also possible if there is temporary ischemia, and seizures, syncope, and migraines can also mimic symptoms of stroke and should be considered on our differential. On the other side, we have diagnoses outside of the brain. Hypoglycemia and hyperglycemia can both cause stroke-like symptoms. Additionally, movement disorders and drug toxicities should be considered. Going back to our workup, since hyper and hypoglycemia are easy things to catch, we'll want to get a point-of-care glucose as soon as possible. And as we collect items from our history, exam, and tests, we want to keep our differential in mind. All of the things we ask about or assess for should be helping us rule in or out items on our differential. The first important one being last known normal. You can ask us of the patient if they are coherent or ask some other historian who might have witnessed some of their symptoms. You'll also want to ask about associated symptoms. Do they have signs of seizures, such as abnormal movements or loss of consciousness? Did they have any headache associated with this? What was the onset like? Was there sudden severe pain that might suggest SAH? And do they have a medical history of diabetes? Last used anticoagulant is also important since this can play into what interventions the patient is eligible for and when. Also, recent surgeries, specifically ones to the spine and brain, similarly influence eligibility. If you have a colleague with you, you can ask them to do a chart review and start assessing the patient for contraindications to TNK or thrombectomy. On exam, there are three main components to consider. The first being a neurologic exam. Use the NIHSS scale on MD-Calc to determine the level of risk of stroke for your patient. The score is out of 42, but even a low score less than 5 doesn't rule out stroke. It just helps us determine the risk for stroke. Three important factors to consider are facial paresis, arm weakness, and changes in their speech. A cardiovascular exam should assess for AFib, and your MSK exam should assess for signs of a fall because this could influence their risk for bleeding. All the while, it's important to keep in mind the timing of all of these interventions and assessment. If during your exam the CT scanner becomes available, you'll definitely want to move the patient to get that non-contrast head CT, even if that means interrupting your exam, which is why I have this red box kind of at the same level as the orange exam box. You'll also want to order some tests, but we'll get to those results later because sometimes the results come back after the non-contrast head CT. So looking specifically at the CT, we're trying to distinguish between ischemic stroke and hemorrhagic stroke. If the patient demonstrates a hemorrhagic stroke, represented by a hyperdense area on CT, they'll need evaluation by neurosurgery. And in the meanwhile, you can help with management of their blood pressure, usually aiming for a systolic of less than 140, but not too low.
Ischemic stroke, on the other hand, should appear unremarkable on CT scan and
Allows us to consider IV thrombolytics. In the case of the brain, we use TNK. We can consider this if the patient is eligible. That means having symptoms develop in less than 4.5 hours and meeting several of the other eligibility criteria. TNK, or tenecteplase, helps break down clots that might have developed, causing the ischemic stroke. Before and after TNK, we want to allow the blood pressures to remain relatively high with the SBP goal of less than 185. Perhaps the patient is not eligible for TNK due to active bleeding, let's say. We should still evaluate them for their eligibility for thrombectomy, which is where the thrombus is mechanically removed. Patients are eligible if the symptoms occurred in less than 24 hours of presentation. If our patient is eligible for a thrombectomy, our blood pressure goals are similar to that of patients undergoing TNK, with a systolic blood pressure of less than or equal to 180. Regardless of TNK or thrombectomy eligibility, you should also consider adjuncts. These include antithrombotic medications, aspirin, as well as DVT prophylaxis. It's very important to remember that TNK and thrombectomy are not mutually exclusive. In other words, patients can get none of the interventions, one of them, or both. Now, going back to those tests that you hopefully ordered early on but may have not gotten the results right away. That would be a CBC to assess for blood counts, especially low platelets. You'll want to assess troponins for strain on the heart and assess PT, PTT, and INR. Lastly, EKG can help you assess for AFib to corroborate a cardiovascular exam that you may have identified an irregular rhythm in. Again, these 4 tests are important to get and helpful in distinguishing between diagnoses. However, getting these tests should not delay the patient's ability to get a non-contrast head CT or even TNK unless the history and exam are highly suggestive of active bleeding, for example. Then you may want to wait for a platelet count to come back, as well as PT, APTT, and INR to return before providing TNK or undergoing thrombectomy. All right, so to summarize, if a patient presents with symptoms concerning for stroke, you'll want to assess their ABCs first. Make sure they have monitor, oxygen, and venous access, and get that point of care glucose as soon as possible. You'll want to be keeping your differential in mind as you ask about their history. Last known normal is very important to assess because this changes what they're eligible for if this is an ischemic stroke. On exam, you should look for things like AFib and signs of falls or bleeds, and calculate an NIHSS score, which assesses for their stroke risk. Time permitting, you should collect the 4 tests. However, these tests should not delay a non-con head CT. In the event of hemorrhagic stroke, we'll end up deferring to neurosurgery, but they'll probably ask for systolic blood pressures to be less than 140. If this is an ischemic stroke, then we need to assess whether the patient is eligible for TNK and or thrombectomy. Remember, these are not mutually exclusive, so the patient can get none, one, or both of these interventions. And while you're getting these assessments performed, hopefully other tests have resulted and can inform your differential. Your time is precious, so thanks again for joining me for this talk. Until next time.